So for those that haven't seen or met me before, my name is Abby. I'm one of the nutritionists at ABL Health. And we've got a big panel today. We've got Jodie with us from Salford Royal. But then we've also got some of the bariatric team from Castle Hill Hospital because tonight's session is hearing from the team at Castle Hill for our Lincolnshire patients. Do you guys want to introduce yourself?
Oh, hi, I'm Claire Hunt. I'm bariatric specialist nurse. I'm currently retired and returned, and I'm now doing a job share with Alison Patterson. So we sort of share the week, basically.
Hi.
Oh,
I was going to say I'll follow on from you, Claire. I'm Alison, so I'm the other half to Claire, and I've joined in the last few months.
Hi, I'm Tom. I'm the bariatric dietitian. I'm full-time at Castle Hill.
Maria, do you want to go next?
Yeah, I'm Marie. I'm the psychological therapist in the team.
Good evening, everybody. I'm Mike Pellon. I'm one of the 3 bariatric surgeons based at Castle Hill Hospital as part of the Hull and East Yorkshire NHS Trust. So I know I'm not massively useful to a large bunch of folks who are in the Northwest, but for the North East Lincolnshire, North Lincolnshire, Hull and East Ridings of Yorkshire population, we provide the Tier 4 bariatric service for them. And I'm one of the 3 surgeons for the unit.
Thanks, guys. So tonight, to start with, we're going to hear from Mike, who's going to talk to us a bit about bariatric surgery. If you've got any questions, will you pop them into the Q&A box? And after we hear from Mike, we'll be able to ask the panel these questions. Unfortunately, when they go into the chat, they get a bit lost amongst everyone, saying hi and having a little chit chat. So if you just make sure they go in the Q&A box, so we can make sure we try and get through answering those. I'll let you get started, Mike.
Okay, right. Well, thank you very much. I'm going to do my very best to share screen and try and get the presentation up and running if possible. So let me check if this is going to work. Can I just double check with you that you can see the first screen?
Yeah.
You can?
Mike. Yeah.
Right. Okay, so what I just want to do is really just give an overview of the interventions that we provide in our service at the Tier 4 level. As I said, I'm Mike Pellon. I'm one of the 3 bariatric surgeons, but we very much work as a team, just like the Tier 3 ABL team does. So as you'll gather, we don't just sort of throw an operation at somebody and say, right, here we go, we'll do something, we'll do an intervention, and you sort of crack on and find your way, and find it online or work it all out. And I probably have to say at this point in time, we're getting quite a bit of that experience from patients that do go overseas and elsewhere, and that is pretty distressing for them when they find out that there's quite a lot of support needed both before and after a weight loss intervention journey. It's not just about the procedure, and I can tell you now, we can do many procedures on people and they will succeed perhaps in the short term, but long term they will fail without the correct support. So every single member of our team is absolutely critical to success. Right, so I just want to talk about a few things in general, right? So we know that if you gain weight and you get into a situation with your weight gain that is above a healthy level, it's going to become obesity or morbid obesity, and there's some complications in health with that. I'd like to talk about our service, the benefits of weight loss, endoscopic and surgery, generally laparoscopic or keyhole surgery for weight loss, and some considerations that you'll need to make in preparation for it. So look, we know that there are some classic, what we call sort of metabolic diseases that go along with obesity, classically high blood pressure, type 2 diabetes, sleep apnea. But of course, it can run into degenerative joint disease becoming worse. We can see situations with an increased risk of cancer prevalence in populations who are overweight. There's now good evidence to suggest that. And also there's psychological issues, self-esteem. There are issues around patients isolating themselves because of it, or indeed their whole degree of freedom to engage in life in limited mobility, limited to work in the workplace. All those factors feed into it. So the benefits of weight reduction are not limited to just becoming slimmer, is of course the main message from what we provide as a service. Preparation. So we follow on from the tier 3 pathway, which in our experience is usually a 12-month minimum duration. Some patients very rarely might get fast tracked through for personal individual circumstances where the tier 3 process isn't serving them in the way it might others. But generally, the benefit of that service, as we see it, is it optimizes patients. Some will do incredibly well with the correct advice, with dietary management, with psychological support, and they will find that they will bring their weight down and they'll bring it under control. They'll develop the habits and the lifestyle changes that they need, and they'll succeed, and they'll avoid all of the fears and the worries and the risk that go with surgery. That's not to discount surgery. It's just to say that, we want people to succeed with weight loss management if they can without, because that's clearly far better for somebody if that can succeed. But we then become involved, and we're a team, not just myself, as I said, but we have we have 2 bariatric specialist nurses, Claire and Alison, who you've met briefly. Tom's our specialist dietitian. He works solo, okay, in our unit. I know other units do have more. We have Marie Acton, who's our principal psychotherapist. She does have colleagues who do support and service, but is exceptionally critical in having such a vast experience in looking after patients who fall into the problems with morbid obesity and the surrounding issues. And also we are supported by a specialist endocrinologist, Dr. Kamruddin Mohammed. He also has a specialist nurse that works alongside him. So we have a comprehensive and robust multidisciplinary team, and we have individual consultant anaesthetists that then help to assess those who we see as particularly high risk potentially to undergo an operation, so that we can optimize them, do any extra tests that we might need to do just to make sure somebody's safe to go through the pathway. So what do we do beforehand? Well, the assessment is undertaken beforehand by our dietitian. That's not discounting the fact they've been through a process with a specialist dietitian already. Of course they have, but there are different needs and considerations for surgery. I don't want to steal Tom's thunder, and you'll discover that in due course, I am sure, but we do have to make sure patients understand that there are permanent restrictions usually with these types of interventions, changes in eating habits, when you can eat, what you can eat, separating fluids, a commitment to supplements long-term, and these understandings need to really be taken on seriously. Some people come to us and say, well, I don't want to make that change forever. I just want to do that temporarily. And it's critical that we make that clear. But of course, we do know we live in an environment which is what's sometimes known as obesogenic. You live in England at the end of the day. We are basically a product of the environment we live in. So we now have loads of processed food, and that's convenient to get to, and we don't cook it from scratch because we don't give ourselves time to, or we lost that sort of skill 2 generations ago. So we now don't really know what goes into our diet, and a dietitian is critical to just really taking us back to basics and understanding that. Right, psychological factors, that is critical. We find we screen all patients in our process, our service in order to just ensure that we're not missing anything, because some people have been through emotional abuse, trauma, bereavement, physical abuse. They have a formal mental health condition in the background. Those all need spotting and identifying at the start, because I have had, and we have all had, many an experience where somebody might have slipped through that net and we haven't picked it up, but we picked it up a bit later on. And it's really important to get it right first time, because when we talk about interventions to bring weight down, let me tell you, getting it right the first time is utterly critical, and therefore getting everything, as they say, getting all of our ducks in a row and prepared at the outset is important, because if we don't spot those early on, that could be the reason people get weight regain, then it's a really disappointing result from going through something like a weight loss operation. Medical conditions, talked briefly about that before. We screen for certain medical conditions if they haven't been spotted or tested for by a GP in primary care, and that does sometimes happen. So some people might come to my clinic, their blood pressure is really high, that's not been picked up. We get it treated, we make sure people are in a safe space prior to going under any sort of general anaesthetic for an operation, that sort of thing. Clearly, if somebody's got a medical condition and it's going to need longer, if somebody's got a mental health condition and it's going to need more time out with the weight loss service journey, then sometimes we need to discharge somebody back to their GP, get all of that straight and optimize, and then welcome somebody back if they're in the right place at that time later on. We talk about everybody in a room together and make sure that we understand each individual patient's circumstances. We don't just generalize. We know that each patient has got an individual journey that they're on, and therefore we review that, make sure that we're supporting them to the point where we either move forward or we have to make a decision sometimes that we can't. They haven't made the changes, they're not ready to make the changes, they're not in the right place, and then we may have to discharge people from the pathway. But we don't do that lightly. Okay, we're here to help people. Right, benefits. Look, body mass index is banded around. I bet everybody on this meeting is well aware of this, but body mass index is that ratio of your ideal weight for your height. Range 20 to 25 is looked upon as optimal, so 25 being the top end. So if we did some maths and you were 5'6", and you weighed 70 kilos, that would be your ideal body weight for that height with a BMI of 25, so they say, okay? But if you were double that at 22 stone, at 140 kilos, your body mass index would be 50, carrying twice as much weight. So that's the parlance, that's the kind of the sort of the lingo that we tend to use that keeps us on the same page. We know people don't agree that body mass index is always the best indicator of weight, and it could be skin fold thickness and all these other things, but we have to have something so we can compare our interventions, see how people are getting on, and also see how different interventions work compared to the others. And what we tend to see with our operations, this is operations now on this slide that's just popped up, this picture, is that we tend to see patients losing somewhere between 65% and 70% of their excess weight by about a year to a year and a half down the line. Okay, that's what we tend to see. And then it plateaus. So it flatlines at that point, usually. Okay, so people don't keep losing weight forever and ever and ever. It does thankfully stop and it balances out. Now, that journey is quite steep to begin with weight loss, and then it sort of shallows out as time goes along. But that's an average, okay? That is not everybody. Some people lose less, some people lose more in terms of their journey. And we follow people up, obviously, in the clinic between myself or the dietitian and bariatric specialist nurses, just to make sure people are on track. Because if they're not, we can usually spot a pattern as to what's actually the cause of why they're not. Okay, it's pretty predictable in terms of weight loss. So overall, if you lost half of your excess weight, and by excess weight, by the way, I'm talking about that difference between your current weight and your ideal body weight for your height. So 50%, you get halfway there. 100%, you're down to a body mass index of 25. That's just pretty rare, but some people do it. So what we're saying is that, you know, if you were 140 kilos or 22 stone, you might lose 5.5 stone by 6 months down the line. By a year down the line, you're likely to have lost about 8 or 9 stone. Okay, and that is quite typical of these types of intervention based on that 22 stone start weight. So that's just a diagrammatic chart to sort of show that it's very, very faint, I know, but this is UK data, right? It's not something that we found from America or somewhere else. This is from a survey of weight loss patients from our bariatric registry, slightly out of date now, but it just shows that gastric band, which we don't do in our unit anymore, is a very poor long-term weight reduction method. And you can see that was the poorest performer out of all of them. Followed by the sleeve, it says about 60%, but in my experience, it's certainly more. It's more like 65% on average excess weight loss. And then the bypass there, Roux-en-Y, gastric bypass at about 70%, which is about right, really. The other upside, apart from the weight reduction, is resolution or remission of a lot of these medical conditions that people get. Now, we can't say that it cures it. You're not allowed to say that, because, of course, if somebody's weight went back up, then, of course, that condition might return. But the fantastic thing is many patients with sleep apnea come off their CPAP machine. Patients with high blood pressure come off 3 medications and go down to 1 or half a dose of 1 or nothing at all. Type 2 diabetics, we can see patients not require any type of diabetic medication whatsoever, having been on medication through tablet form, from injectable therapies, for up to a decade before. So we can see considerable improvements in lots of medical conditions. And that is something that we discuss with patients individually as well. So the interventions, endoscopic interventions, I need to touch on this because it is relevant to our service, but not a definitive treatment in our service, and that is endoscopic intragastric balloon. So where do we use a balloon inside the stomach? You'll have heard of different types of balloon, different places, and on the internet. You can get swallowable balloons and balloons that expand by different ways. We don't do that. And the reason, personally, I don't feel that we should do those is because we've got no idea where that ends up. And we don't know what it will do if it floats off down the intestine. So the way we do our balloons is endoscopically, and that is a camera going down. I've got a little animation coming up. Don't worry, you don't need to worry about being squeamish. It's an animation. I'll show you in a tick. But the gastric balloon we tend to use is for those patients who we don't think, or we've established, need help getting the weight down, but they're not fit to undergo an operation. Okay, so those patients, we'd love to offer them an operation, but they can't. The anaesthetist said, it could be lethal if we put them under a general anaesthetic, so we can't do it. For some patients, they just don't want an operation, but they do want help. Tier 3's done everything it can. It's that attempt to try and see if we can kickstart some degree of weight loss for them. And then we can sometimes use the balloon to try and get somebody's weight down who's incredibly heavy, such that we can't access their tummy with our keyhole instruments, or they're not fit to undergo the anaesthetic at that time. So we sometimes stage somebody's weight reduction using a gastric balloon, maybe for 6 to 12 months, then balloon out and stage and go on to do the operation at that stage. So they're the main roles that we use for the gastric balloon. What's a gastric balloon? That's what it looks like. It's a silicon polymer, and it contains basically sterile water. We put a dye in, so it's not actually white. We put a blue indicator dye in, and that is basically so that if the balloon pops, heaven forbid, very rare, thank the Lord, but if it does pop, it actually changes the colour of the urine green, and that means your balloon is leaking and you need to have it removed. That's the reason we use a dye in it. What do you expect from a gastric balloon? About 2 or 3 stone in excess, 2 or 3 stone in weight loss on average, okay? Some heavier patients might lose up to 5 stone, but for some patients it just doesn't work at all, and that's why it's not, and it's no way near as guaranteed sort of a predictable weight loss intervention as the operations I'll be discussing in a tick. Here's a little animation. Let's just check it works, and I can hopefully talk you through it. It says, I shall click it again. Finally. So an endoscopy you'll be familiar with. Normally it's a 4 or 5 minute camera test, an endoscopy, but in this case it takes more like 15 minutes. It's with throat spray or a sedative. So you're not knocked out, you're just sort of a bit sleepy if you have the sedative. And we inflate the balloon in the stomach so that it has a volume of somewhere between 400 to 700 mils in capacity. And what that does is it both takes up space in the stomach, so it makes you feel full quicker. It also slows stomach emptying, so food takes far longer to travel into your intestine. So a meal from a couple of days ago might still be digesting in there. So it makes you feel fuller for longer. And by doing so, what it helps you do is achieve a degree of expectation in terms of portion size over those meals per day in conjunction with the dietitian's advice. What we tend to see with that intervention is most people lose most of their weight in the first 3 months, then they tend not to lose a lot more weight after that. It just sort of maintains the weight loss. The upside, you haven't had an operation, you've just had an endoscopy, the weight has helped you to get the weight off. The downside is that the weight loss expectation is less. Second thing is, a bit like some people who do brilliantly in tier 3 or do brilliantly in Weight Watchers, who do amazingly with Slimming World, they may achieve a considerable amount of weight loss, 3 stone, 4 stone maybe. But the risk is their balloon comes out and they haven't made the changes in lifestyle. They slip back to buying the same things from the supermarket week in, week out. Weight creeps back on. So weight regain is a risk of this type of intervention. So it doesn't offer what the surgery does, which is weight loss maintenance. Okay, that's one of the risks with a gastric balloon, which is why we tend to use it as an adjunct, as a temporary intervention, or as a stepping stone. So things to just think about with the gastric balloon as well, can make you feel quite sick, crampy, and reflux or even vomiting for a few days afterwards. So it's not a pleasant thing to have in those first few days. Many patients are quite surprised at how unpleasant it is. Okay, the effects are pretty temporary and it usually resolved in about a week, but it's contrasts quite a bit to an operation. An operation, you don't feel, well, you might feel a bit sick for maybe a few hours after the operation, but most people don't experience vomiting, reflux and sickness feeling for very long at all after an operation. So it does have more side effects in the short term, I would say, compared to operations. We also know that if you can't tolerate a balloon and it's in your stomach and you're desperate to kind of, have something done about it, sadly, all we can really do is pop the balloon and remove it, and that's disappointing. There are some risks, but they're pretty rare. So it can spontaneously leak and slip, turn back into its tube and slide downstream. It can also risk problems with vomiting on old food going up into the airways. That is a rare risk, but it does mean we have to take special care of patients when they are having a gastric balloon removed, that is for sure. So that's really gastric balloons. That's all I really want to say about them. And I'd rather just formally talk about the operations that we tend to do. Now, there are lots of operations, and as I mentioned to you, there used to be operations called, some people still do things like the gastric band. The vertical banded gastroplasty was an operation that was done about 20 years ago. That was just found to just be ineffective long term, have lots of complications long term. More interventions are coming out all the time. The issue is that we have to make a decision as a service that we provide an operation that's got the right balance of effectiveness. It works. We know it works. We've got evidence to say it does, and it works in our hands, and it's on balance safe. Nothing is, of course, completely risk-free, but we choose the gastric bypass and the sleeve gastrectomy as operations that we feel deliver that. That's not to say there aren't others that evidence might come out in due course as being effective, but we don't do them at present. Okay, so that's my disclaimer. I'm not saying that we're right. I'm just saying that in our experience, we're comfortable that we give a good result for our patients with a good risk balance. So before an operation, we talked to you about something called the 2-week liver shrinkage diet. You will probably heard about that before. What is it? It's a very strict, very low calorie diet. It's somewhere in the order of about 700 to 800 calories intake per day. Okay, so it's very correct, very carefully spelt out for you. But the reason we do it is not to make you lose a stone in weight, but you will lose a stone in weight, no doubt. The reason is to shrink the liver's stiffness so that we can gently lift it out of the way of the stomach, because it sits in front of the stomach. And if we can't do that, if it's so rigid and fixed and heavy, we simply can't access the stomach. We have to abandon the operation. So it's critical. It's a critical step in the safety of the operation. So I'm going to talk about the gastric bypass now. So when we do the operation, we generally do it through keyhole surgery under general anaesthetic. It takes about an hour and a half. And during the operation, we access the tummy cavity using telescopic instruments because we can blow the tummy up with carbon dioxide gas. So we relax the abdominal wall while you're asleep, and we get access using the telescopic instruments. Now, what we actually do in the procedure, I've got a funny feeling this is a sleeve and not the bypass, so I do apologise. But in the procedure, what we do is we use a calibration tube, which is passed from the gullet down to the end of the stomach. And then we use a stapling device, which serially divides and seals the stomach all the way up until we get to the top. And we've removed and partitioned about 80% of the stomach. Now that comes out permanently, which does potentially sound quite a dramatic intervention to do, but it actually is perfectly possible to live without that 80% of the stomach, and it yields that you feel fuller quicker, and it reduces your peckishness. It drops your hunger levels because we remove a hormone that's produced in that part of the stomach called ghrelin. Now, that hormone is still produced in other bits of your gut, in your small intestine, but at a much lower level. So we harness the effect in that 12-month journey of both feeling fuller quicker and your appetite being much lower than it was before. So that desire to snack and graze between meals pretty much disappears, even when the stomach is empty. Doesn't mean that you feel sick. It doesn't mean to say that you've gone off food. You just tend to not fancy eating. And that's what patients tell me. So they sometimes have to remind themselves to have a meal. Portion size, usually about what you can fit in the palm of your hand, believe it or not. So you go from having a normal size meal to starters, and you can't eat and drink at the same time. That's something patients struggle to get their head around sometimes. You can only eat your meal and then drink an hour before or an hour after that meal. Okay, otherwise it adds to the tube suddenly distends, stretches, and you're sick. So it's not a pleasant feeling to have, and patients quickly understand that, but it does take a bit of getting your head around. Let's compare that. Oh, sorry, before I say that, so what can you expect to get from it? You would expect to lose about 65 to 70% of your excess weight. So we talked about that with the maths before. Risks, there are risks. A risk of leak from the staple line, which is rare as anything. We do know how to deal with it if it happens, but it could require further surgery or a longer stay in hospital. Bleeding, well, there's good blood supply to the stomach. It's pretty rare that it requires another operation, thankfully. Stenosis or being too tight. Well, I use a tube, we all use a tube to make sure that it's not too narrow, but there's a small chance that the tube could kink, and that could cause problems that might need further intervention. There's risk with any surgery of thrombosis or clots, and we mitigate that by providing patients with a blood thinning injection known as Fragmin. It's a form of heparin, as well as other interventions to try and get you going quicker and keep the calves, which is the source of those types of thrombosis, compressed as best we can after the surgery. Reflux can affect some people after sleeve gastrectomy, and that's because the tube has gone from being all sort of a saggy, open, distensible and stretchy stomach space to quite a narrow tube now, and that narrowing causes an extra pressure in the stomach tube, which can cause back sort of acid reflux. So for some people, that's a bit of a downside to it. But for most people, what they find is they lose weight after the sleeve and their reflux gets better anyway. The only slight exception to that is if you have if you have a hiatus hernia where your stomach is a bit weak and it's slipping up through the diaphragm, we often have to correct that surgically just to make sure you don't get horrible reflux after surgery. But it's pretty rare that people do. Risk to life. There's a risk to life with any operation, actually, if you were to look at the maths of it all. However, it's incredibly rare, and we have to monitor our patients post-operatively in a higher nursing environment just to make sure we're not letting our patients come to any early warning harm. But we do various things. We do lots of paranoid checks, if you ask me, which I like to do and I'll continue to do. And then we do a leak test during the operation. We do a leak test with a swallow test the day after the operation in our unit. We have our specialist nurses give you a buzz probably about 7 to 10 days after the operation, check you're okay, make sure there's no early warning problems. And of course, we follow you up and we chase you up if we can't get in touch with you. So we do as much as we can to make the process as safe as possible. Right, now I'll talk about the gastric bypass. Now this one, some people, well, most normal people, I would say, would really find this a bit more tricky to get your head around because it's not quite as simple as permanently removing part of the stomach. In this operation, we don't remove anything. Okay, we do not remove any parts of your anatomy, but we do rearrange it. And in this operation, we use the same very expensive and clever triple stapler to divide the top of the stomach and create a small pouch. Food enters that pouch. It has now got nowhere to go, so we have to give it somewhere to go. So we take the intestine from downstream. The downstream means it's missed out the enzyme circuit. So we hand stitch or staple on that small intestine to the pouch. The food travels through that bit of intestine, but as it travels through, it isn't being absorbed as efficiently because it has not yet mixed with the enzymes which degrade it into its sort of basic building blocks that you can absorb across the intestinal wall. So when the enzymes are plumbed back in, which we do with a second join, that's where you start absorbing a lot of the calories, but the protein and the vitamins and the minerals, etc. The operation takes that one takes about an hour and a half, and it's a little bit less for the sleeve gastrectomy. The expectations of weight reduction are on average a little bit more compared to the sleeve, though I can tell you I've had patients who've had a sleeve who have lost just as much as any patient who's had a gastric bypass. So it's tricky to say that one is necessarily better than the other, but on average it does tend to see a greater weight loss overall. What else? Well, we do know there's some risks. Okay, we've talked about leak. There is a risk of leak in this operation. There's a risk of bleeding. There's a risk of narrowing at the junctions between those joints, yes, as well. However, a couple of specific things to think about is anastomotic ulcers. We do not like patients to continue to smoke if they smoke already for this type of surgery, because they are an absolute sitter for getting an ulcer in their lining of their stomach, which will probably never heal and might actually end up causing a long-term leak. So that for us is a massive no-no. Smoking really has to be stopped. Similarly, things like anti-inflammatory medications, we really want people to have stopped, just because they can, again, cause problems with healing of the stomach. Specific to this operation is something called internal hernia and more adhesion risk. So that's scar tissue or a kink or twist in the bowel, because we're involving the small intestine with this operation. Now, we actually close the gaps that an internal hernia gets trapped in these days. We didn't used to 15, 20 years ago. We do now because we know it can happen. But it's just to say that we've sort of learned from experiences of the past. So I would say overall, this operation is considerably safer than it was in years gone by. Dumping syndrome is more of a side effect than a risk. And dumping syndrome is a situation where, counter to what I said before, where if you sort of drink liquid at the same time as eating, you might be sick. What it can do is it can flush everything into your intestine too quickly, cause lots of changes in sugars, lots of changes in absorption, and you end up feeling incredibly faint and feeling very unwell. And our dietitian, Tom, makes sure you're very clear on what not to eat and what consistency. Generally, smoothies, liquidized stuff, lots of sugary drinks, which we wouldn't really expect you to be on at this point in your weight loss journey anyway. Those are to be avoided, otherwise dumping syndrome will happen. Thrombosis we've talked about, risk to life we've talked about, so similar to before. But overall, complications, and I'll put the fear of God into everybody now. Gosh, if this is a dangerous thing, what on earth is this? But actually, complications, this is statistics from my own data, those can occur in less, and this is everything, in less than 13% of patients, right? So 87% of patients, nothing happens. It's pretty straightforward. But the types of risks that you might see are a bit of swelling, which might lead to us observing a patient in hospital for a bit longer. And that accounts for about 6%. So almost half of those risks is that. It's just a delayed discharge because we just need to look after patients for a bit longer. It's rare, but about 4% of operations or less may require another operation at some point in their 2-year journey. Okay, that's what we've tended to see. Thrombosis risks, clots, is exceptionally rare as well. Okay, very rare indeed. So it's just to give you an idea that, you know, overall it's a safe type of intervention, but the bottom line is we are comparing or taking the risks of somebody who is overweight, they've got morbid obesity with medical complaints or may well develop them in long term, which could shorten their life expectancy or endanger them, versus the benefits of and the risks of an operation, which could get rid of all of those medical risks, and but also has its own small risks. And nothing is risk-free. We have to have that balanced conversation with you, really. Considerations. I'm getting to the end, so hang in there. We do know there's a commitment to lifelong supplements, all right? Some people will get to a year, they will look slim, nobody ever knows that they've had an operation anymore, but the patient's responsibility is to remember that, because absorption of things like iron or of vitamin D and a lot of the vitamins and nutrients that we have in our diet, you're getting less than a third of that perhaps than you used to. So taking a multivitamin or other supplements such as B12 or in some cases vitamin D are essential lifelong, and we give you very clear guidance on that. We also do blood tests and recommend ongoing blood tests just to keep track to make sure that the levels aren't falling. We've talked a bit about dietary patterns, and our dietitians talk about that. So thinking about the fact that you may have to separate fluids from meals, thinking about those smaller portions, going around for dinner at a friend's house and they look at you going, do you not like my food because you've not finished a plate of food? I haven't told you I've had a weight loss operation. I wasn't going to, and that we've seen patients sort of think about those sort of social anxieties to a certain extent, but you have to get your head around the fact the portion size that you'll be able to manage is much smaller after this type of surgery. Family planning and contraception. The upside of weight reduction for ladies is their fertility can improve significantly. However, as anxious as somebody who has been challenged by wanting to start a family but hasn't been able to because of their weight, we do suggest strongly that it's not safe to fall pregnant within the first 18 months after surgery, and that is because the baby simply will not get enough nutrition across the placenta, and therefore you get risks of having a baby that is small for gestational age or preterm, so preterm delivery. So there are risks nobody really wants to experience, so that's why we recommend that. Smoking, I've said that already, okay, it's not that we've got anything against smokers, it's just not good for you on several levels, but if this type of surgery is being contemplated, it's frankly dangerous.
No, it's okay.
Side effects. So complications we talked about, but there are some considerations. If you lose weight and your weight's been on the heavy side for a while, you can develop loose skin, okay, and some people wish to seek cosmetic intervention. Some people are just not fussed. Frankly, they've got the life back, they've got the mobility back. That's good enough for them, which is great. Gallstones, okay, gallstones are very common in England, all right? 1 in 5 people get gallstones anyway, but losing weight, unfortunately, is a risk factor for getting gallstones, whether you do it through an operation or otherwise. Thinning of hair, patients get really annoyed about this. Their hair falls out in the shower between months 3 and 5, and they're kind of a bit upset about it. It grows back, it thickens back up again, but it is a bit of a temporary effect of, we're not quite sure whether it's protein, whether it is the shock to the system because of the significant calorie drop, we're not quite sure, but it reverses itself, so it's not a long-term thing. Follow-up. So we do look after you. We follow patients up for 2 years with dietitian and bariatric nurse support. We monitor blood profiles. We keep an eye on patients and add them to the registry, which is a requirement for all good bariatric centres. And that allows us also to make sure we can identify those early complications. How do you know that the pain you're getting or the symptoms you're getting are to worry about or not to worry about? That's what we help do. And your GPs, God love them, they don't necessarily know what the rarer kind of complications are, and that's what we're there to make sure we help supervise and support your GP with. We usually discharge and hand you back at 2 years. That doesn't mean to say we never want to see you again if you are running into trouble. Of course, GPs can refer patients back, but at that point, patients have reached a stable point in their journey, and we give advice on discharge at that point in terms of blood tests and supplements to continue. So that's it. Okay, that's as much as I want to say today. I just want to let you know that the BOMS website, the British Obesity and Metabolic Surgery Society, hopefully you'll be able to see the web link at the top, screenshot it. I think it's been recorded anyway, this whole presentation. There's a bit on patient information there as well, so you can have a look at that as well, and that might just direct you to the correct resources. Second thing to say is you're very welcome to look at my own website. On there is a little bit under services, which allows you to look at some of the animations that I've already presented to you today, just so that you can listen to me waffling on yet again, but over those videos of those operations again. And there's a little bit of a frequently asked questions bit at the bottom, which might answer a few questions, because you can put the fear into you by going on the internet and scrambling around for information from different resources. There are obviously plenty of other opinions out there, but I just wanted to make sure we gave you a fairly balanced one today. So that's it from me, and I'm going to stop talking at this stage. Thank you.
Thank you, Mike. That was really informative. Got a lot of people in the chat thanking you for that. Lots of thumbs up. So we'll have a look at some of the questions. We have been typing away to try and answer some already, but I'll try and pick out some key themes. that people have been asking. We have had a few questions around the importance of the mental health assessment within Tier 4 and what the outcomes could be of an assessment. So could someone be discharged from Tier 4 after their mental health assessment?
I'll answer that, Abby. So when people come into the Tier 4 pathway, and particularly when they've been through a Tier 3 pathway, we are quite hopeful that very few people would come out of the pathway at that point, because generally they've done the work that needs doing in Tier 3. There are some things, I suppose what we're very keen on as a team is that once people get into that surgical pathway, they stay on that surgical pathway, but also that it's healthy for them. It's healthy from a psychological perspective, it's healthy from a physical perspective. So we would always sort of highlight there's sort of certain red flags that would mean that I would see somebody for a more detailed assessment. So the screening assessment's really quite short, probably about 40 minutes, and that would highlight whether I need to see somebody for a bit longer. Things that would highlight that are pre-existing significant mental health problems, where they've been involved in secondary mental health services. So they've seen a community psychiatric nurse, they've been an inpatient, that sort of thing would mean that I'd sort of need to do a more detailed assessment. We're looking at quite a lot of people will have some disordered eating, and we might do a piece of work with them. Usually that's been done in Tier 3, they've been through a Tier 3 service. If people have an eating disorder, we would want that to be treated before they come through to surgery, because the outcome at the other side of surgery would be really quite sort of well, it wouldn't be very good. I think it will put the person at significant risk from a health point of view with that. So if there's an active eating disorder, that would be one of the things that we look to sort of signpost out, and then for people to come back into the service. Again, hopefully that would have been picked up at Tier 3, and that work would have already happened. So by the time they're getting through to us, we're not really seeing much of that. Bit of depression and anxiety, I think, are part of the course and just come with the territory. Not overly bothered about things like that. Again, what we'd look at is if it was significant depression. There's some research there that says that the outcomes in terms of weight loss post-surgery are less for people with a significant depressive disorder. I think people find it more difficult to sort of adjust and things. So it really is a case-by-case basis. There are things that would put a red flag in place. I don't sort of discharge anybody following the screening. What I would do is highlight that they need a full assessment, where we've got a little bit longer to work with local services to get people in the right place for them to have the surgery.
Brilliant.
Does that
Thank
answer
you.
that, Abby?
It does, yeah. And someone had asked specifically about eating disorder and if they would be put through to Tier 4 or be referred back to their GP for that support.
Yeah,
they
would definitely be. If it's an active eating disorder rather than disordered eating, I would suggest that what they do is sort of seek out some treatment for the eating disorder, because we wouldn't put somebody through for surgery if they've got an active eating disorder.
Yeah, okay, thank you. Mike, you mentioned about the danger in smoking and how it can impact on the safety of the operation and outcomes. Now, some patients have asked about, some patients are working towards quitting smoking while on weight management and so are struggling with the weight loss. Has anyone got just any advice at all for these patients? I'll open it to anyone.
I don't know, do you address that at Tier 3, smoking cessation?
We do, yeah. So on our service in ABL Health, in Oldham, we have an internal smoker cessation service, or we refer and signpost out to external. Yeah.
Again, probably for us, and Tom, you pick this up as well sometimes pre-op, don't we? We would probably suggest going back to GP for smoking cessation support. That's kind of how we would address it within our Tier 4 service.
Is it? I think what you're getting at is that some patients, they see the weight rocket up when they stop.
After they've stopped, right? Sorry, yeah.
And
Yeah.
I mean, that is a problem. You know, we do have to sort of take that in consideration. I think the tier 3 process does, you know, recognise that some patients don't lose weight, but have reached a conclusion at the end of that year that they still want to progress to an operation, and then they will recommend onward referral. What we see mainly as a red flag is somebody whose weight is continuing to increase and they can't get it under control and stabilise it and almost flatline it, if nothing else, because that means there's some unaddressed issue from our perspective that is going to continue even after we've done the operation, and we're not going to win. As far as adjuncts, look, we don't particularly have anything against vaping. I'm not endorsing it. It's just that I'm saying that we've seen it has been quite effective for some people. And so there are obviously different options for people. We do recognise, of course, that the cigarette smoking can suppress appetite and help people keep their weight down. But moreover than that, you know, we've got a responsibility really to ensure that patients understand that it is balancing those meals, it is not the snacking in between, and it is reducing the calorie density in the diet. You know, nobody's got a clue in this country, least of all me, until going through this part of my journey in life, how dense calories are in our environment and the foods that we get. It's packed full of stuff to make it taste brilliant, so that we'll go back to the shop and we'll eat it again and again and again. And the problem is that if you've got hunger pangs, you'll choose the foods which are probably full of carbohydrate, you know, and pastry, and, you know, quickly kind of get your carbs into your body and sugary, and that'll satisfy that. And it's breaking that cycle. And it's a bit like going cold turkey for a few days, getting into the higher protein and higher vegetables and the healthier snacks. And yeah, it sounds boring, but once it's become a habit, that's what makes a difference for patients. And just like smoking is a habit, eating a pattern week in, week out is the habit. It's not the treat thing you have once a week on a Friday. It's what you buy in your shopping basket from Sainsbury's, you know, that is making a massive difference in terms of your diet. So the dietetic element is far more important, and we'll often get patients asking questions. Might as well just address this one right now about, what about exercise? Yeah, exercise is quite important, but it's a tiny fraction of losing weight. Okay, a tiny fraction. We don't make people go and exercise more by doing a gastric bypass on them. We restrict their calorie intake, and that really significantly helps them choose meals which they've got no choice on. You know, they're just going to be smaller portions, but they give all the textures and flavors they want. And then once you start cutting out the sugary content, you don't get spikes in sugar, which make you go, oh, I'm really craving something like that. And that's the thing. The sugar content, the carbohydrate content predominantly in our diet makes us crave foods. Yes, smoking stopping does as well, but if you choose the right things when you get the craving, that's about the best advice I think I can give. Tom, tell them differently.
No, I would agree. I was going to say, in terms of kind of stopping smoking and managing your weight, I think the first thing to recognize is yeah, stopping smoking will increase your appetite. It will make it harder to follow a healthy diet. What Mr. Pellin said there about you know, reducing down sweet foods in particular will have a big impact on that. In terms of kind of the effect it has on your total weight, when you're stopping smoking, during that period when you're stopping, aiming for weight maintenance, I think is a sensible thing to be aiming for. So not beating ourselves up if we don't lose a load of weight, but also recognizing that it is possible to still manage your diet in that process, and you know, weight gain is never an inevitability. That if we kind of manage our diet proactively throughout that period, we can kind of keep our weight stable, and that will help to kind of alleviate a lot of those problems.
Thank you. I've had a few people asking about when they go for bariatric surgery, would there be possibility of gallstones or hernias also being removed at the same time?
I shall quickly answer that one. So sometimes we do, and sometimes we try to deal with gallstones before an operation, rather than put somebody through the risks of them having two operations in one, because if you get a complication from two operations at the same time, you essentially could magnify the risks of the operation overall. Sometimes you do that. Sometimes we, for instance, with hernias, for example, we do the weight loss operation first, get the weight down, a good 50% of the excess weight off, and then we go for the hernia operation, or even later. And the wisdom with that is because recurrence rate in hernia surgery is there. It's a real thing. If anybody says to you that I can guarantee this hernia repair for life, that's a lie, because there's multiple factors which contribute to recurrence of a hernia, and weight being high is one of the biggest. So getting the weight down and stable is really important. And plus, you've got to remember as well that when you're losing weight, nutritionally, you're not in the best position for healing. So we want people to get to a slight balance in terms of their nutritional intake as well. So I preferably do a hernia operation at a stage point 6 months or later when the weight's come down. And we know that lots of risks from hernia surgery are much higher when your weight is heavier. So it's better to just improve your risks overall. But we always have that conversation with a patient if they've got a couple of those conditions.
Thank you. And what about for Salford Royal Jodie? Is it similar, just in case any of these patients asking those questions are from the Northwest?
Sorry, rookie mistake there. So I was actually reading a few of the chat comments there. So just repeat the question for me, Abby. You're on mute now.
About hiatus or incisional hernia or gallstones, would they be treated at the same time as bariatric surgery?
Though we completely echo what Mr. Pellin said, it's very individual, and sometimes before you go in for a surgery, it's really good to have a good idea about all the options, so the bypass, the sleeve, because if there were any technical difficulties and they felt it was safe to proceed with the sleeve gastrectomy, we wouldn't want that to be a big shock to you. So do make sure you do research on all the surgeries. On the day of surgery, you'll be consented, and they may say if there was a hiatus hernia that they found and it was in the line of vision of doing their surgery, they may say that it would be a possibility to repair that, and that's something they would consent you to do. But if you had a hiatus hernia, and the nature of hernias is sometimes there's a loop of bowel going somewhere that shouldn't, sometimes it may be seen, sometimes it may not. So it's not a guarantee that that's going to happen for you in your surgery, but we usually always stick to our primary surgery, which would be your bariatric surgery. And the same as Mr. Pellin said, if you've got a dodgy gallbladder and it's causing you real trouble and it needs to come out, that would take the priority.
Thank you. We've got a question here about if the operation can still be done with a colostomy.
So I guess that's a kind of a technical thing. So it is a technical consideration because of scar tissue trapping the small intestine is why. Okay, so colostomy doesn't involve the small intestine, but the surgery that the person had may well have generated adhesion, scar tissue down in the region of the small intestine, which means accessing that small intestine and bringing it up and stitching it onto the stomach pouch, i.e. the gastric bypass operation, becomes technically very difficult. So sometimes we have a bit of a pragmatic conversation, certainly I do, with a patient and say, well, look, we could try to do the gastric bypass, but we might fail, or we just focus on the stomach, we focus on the sleeve, and we know that then we're not really getting into the realms of dealing with the small intestine and risks of dividing adhesions and bringing the small bowel up. Also, one has to consider that sometimes people have had a colostomy or an ileostomy for a condition like inflammatory bowel disease. And in our experience, we tend to guide patients away from gastric bypass surgery if they've got a history of colitis / Crohn's type of conditions. Doesn't mean say you can't have an operation on your stomach, and doesn't mean say it isn't without its risks just operating on the stomach, but it's probably more sensible, and generally it's agreed at a national level that focusing on a sleeve gastrectomy under those circumstances is wiser.
Thank you. Think about those digestive disorders. We've got a few questions around post-surgery. Some patients worrying about how they're quite limited pre-surgery with their diet because of digestive complications. So post-surgery, is there any changes in IBS or colitis or diverticulitis? And is there any risk of them being malnourished?
I suppose I'll maybe jump in on this one. So in terms of can colitis or Crohn's disease be changed after surgery? I've seen a range of outcomes from people. Some people have seen kind of improvements, some people have seen worsenings, but generally speaking, you already have an inflammatory process going on in your bowel, and the surgery isn't going to necessarily change that dramatically. In terms of kind of nutrition, obviously it's part of the assessment beforehand as to what your diet looks like at the moment, and what kind of level of restriction you already have, and then thinking about what life is like after surgery, so we can see actually, are we going to be able to put together a diet that first of all is healthy, and second of all is one that you would actually want to eat after surgery as part of this decision-making process as to whether surgery is going to be the best option for you. And that obviously is something that you see at Castle Hill, you see myself, or at Salford. I'm sure there's I think there's a few dietitians at Salford, so you'll be seeing somebody at some point during your process who will help you to come to that determination.
Thank you. And Tom, while you're speaking, got a few questions on post-surgery recipe ideas and what sort of food they'll be having and how long a liquid diet would be needed for. Sure.
So in terms of how the post-surgical diet looks, it does vary a bit from centre to centre exactly how places do this. But at Castle Hill, we tend to do 2 weeks of a liquid diet, focusing ideally on lots of nourishing high protein liquids. So that's often things like dairy products. But if you can't have those, obviously we'll discuss kind of alternatives. Then moving on to about a week on pureed textured foods. Then moving on to soft, I like to term them as fork mashable foods, and then moving back to normal foods after that. In terms of the portion sizes, we expect you to be managing something in the region of about an old-fashioned tea plate, so roughly about yay big. About half of it should be proteiny foods, maybe about a quarter carbohydrates and a quarter vegetables. And in terms of recipes and things like that, I don't tend to give out specific recipes because everybody has likes and dislikes. But what we can do is I like to discuss with you what sort of foods that you like to eat, and then discuss how that can look on the plate. So we're making sure we're getting the right proportion of foods, but actually within the types of foods that you already like to eat, rather than trying to impose a specific set of recipes, because I don't think that's ever necessarily that helpful.
Thank you. And what about alcohol and fizzy drinks?
So fizzy drinks after surgery, I think it's uncontroversial these days that fizzy drinks are a no-no after bariatric surgery. You've got to bear in mind the pouch, whether it's a bypass or a sleeve, is a small space. And if you imagine you're having a fizzy drink that contains gas, when you drink it, some of that gas is released in the stomach. And normally that's not a problem, because we've got, our stomach's quite big and it's quite stretchy and can manage the fact that all that gas is there. After surgery, you've got this small pouch and it just can't manage that. And it can be very, very painful, very uncomfortable. It can make you sick. In the long run, it can just get used to the feeling of the pouch being overly full. And in my experience, people who often have them in the long run find that it can be increasingly difficult to tell when they feel full, because actually they've got used to the pouch feeling overly full. And also in the early periods, we get concerned that if we're stretching the pouch too much because there's lots of gas expanding inside the pouch, that we could do damage along the staple line. But for all those reasons, we advise against totally avoiding fizzy drinks after surgery. Alcohol, we have a slightly more nuanced view on alcohol, and when I speak to colleagues up and down the country, there's kind of slightly different opinions and views on it, but we recommend that you avoid alcohol entirely for at least 6 months after surgery, and after that, only have it rarely, basically. There are concerns that people after surgery can develop other addictions, including alcohol addictions, but also the effect of alcohol does change after surgery. We do find that people get intoxicated quicker, and that it takes longer for alcohol to exit your system than it does for someone before surgery, and that people often don't like the experience of drinking alcohol because of those reasons. So if you do want to have it, it should only be small quantities and not on a regular basis.
Thank you. I'll ask the bariatric nurses what their experience is with how patients deal with the pain post-surgery in those first few hours to day of having the operation.
Well, I generally don't find that patients have much pain at all. They are quite comfortable. They will be given some analgesia when they're in theatre, and generally it's normally IV paracetamol that we give. I don't know about you, Jodie. Sometimes patients do need more, but generally they're relatively comfortable after their surgery. Try and get them up and about as quick as possible.
Yeah, we say the same. IV paracetamol is quite nice. It packs a bit more of a punch, so it's quite useful just in that very early stage after surgery, because we want you free of that metal friend with a drip as soon as you can be. So you can be mobilising, because actually mobilising is the key of getting rid of all kind of complications, including things like gas pain. So when the surgeon talks about filling the abdomen with that carbon dioxide gas so they can advance their apparatus and do your surgery nice and safely, that gas has to disperse and it has to eventually pass out as wind, and you want that process to happen fairly quickly. So it's an interesting nerve matrix. So some people might notice they have shoulder tip pain, and that tends to be from lower trapped wind in the abdomen. So moving around, twisting, bending, stretching is all really good for healing, and then all your other complications too. So we want you moving around to prevent clots. We want you deep breathing and huffing, because little secretions can creep down into your lungs during that operation, and all that movement is really good for alleviating all the common post-operative complications such as chest infections and clots. And when I say common, they're really not very common, and our patients are really well versed in getting up and going as soon as they can after, and that tends to mean that you don't you may have some discomfort, but you shouldn't have lots of pain. But pain, again, everyone is very different how they react to pain, so we are prepared to keep you comfortable too.
Thank you. Again, for the bariatric nurses, what's your experience of patients with fibromyalgia or polycystic ovaries as well? These are two specific questions just about their success after surgery and management of the conditions.
Do you want to do that one, Jodie, or?
I'll happily say with fibromyalgia that we could definitely not say that your condition would be any worse or any better. Fibromyalgia is not a nice condition. It's a difficult one to manage. It's a difficult one to diagnose. It tends to be to do with nerve pain, and nerve painkillers can still be taken after bariatric surgery, but as we're learning more and more, evidence is weak for all the different types of chronic pain relief that are given. So you will still have your fibro flare-ups, but sometimes people have said to me they find they're less frequent. They find because they're more active now that good days are really good days, and having less weight makes life easier. So I think there's definite health improvements, but you wouldn't be cured or necessarily be able to boast an improvement due to bariatric surgery for fibromyalgia.
I think it's very individual, isn't it? Some people are really much more improved, and some people still, like you say, have the flare-up. So it is individual, really.
Thank you. Yeah, PCOS. Yeah,
PCOS. Like Mr. Pelham said, it affects your sort of fertility. So Tom and I have come across a couple of patients that we've had little surprises along the way, because it has affected patients' fertility, which is lovely for them, but we do like you sort of to be mindful of that. So again, it's a bit like the fibromyalgia, it's all individual, but we do see well, quite a few of our patients, Tom, haven't they, have had babies and been able to fall pregnant. So
it's come as a bit of a shock to a few people. I mean, the effect of fertility with weight loss varies wildly from person to person. I've had one, I can think of one person I saw who'd not bothered about contraception for years and years and years. 1 month after surgery, lost a reasonable chunk of weight in the early stages and fell pregnant. That was a bit of an extreme situation, but these things can do happen. So it is important that even if you are not taking precautions now, that you take precautions following surgery. And it's worth stating that, at this stage that we don't normally recommend the contraceptive pill because there's evidence of its absorption being less and less effective following the surgery. So it's worth thinking if you're going to go down that, if you're going to have surgery, about your options in terms of fertility, and avoiding surprise packages in the first kind of 18 months or so after surgery.
Okay, thank you. Mike, some questions about previous surgery. So one patient has asked about, they've said they've had 4 C-sections. Can that cause difficulty with things like scar tissues when having bariatric surgery?
So I was just replying to like a text thingy, one of your Q&As. Previous surgery can affect it. So when I see a patient who has previously, for instance, had a cesarean section, which is incredibly common, I have to warn them that there's a small chance that their desired gastric bypass, I might find that the small intestine is tethered down in the pelvis and I can't get it up. Often the small bowel is fine, but the omentum, which is a big dangly sheet of fatty tissue that comes from the colon and covers the small intestine, is absolutely welded to the back of their abdominal wall scar that the obstetricians have not formally closed at the back, and that causes internal scar tissue. So that's a very, very common set of adhesions that I see. But usually I can spin around, use the keyhole instrument, get the scar tissue down and mobilize the small intestine and get it up. Okay, so that's an example of one that we can deal with. Sometimes I've had patients who've had a car crash in the past where they've had a trauma laparotomy, which means they've had a big cut in the tummy, they've had blood in the belly, and they've got scar tissue of everything and anything. And I've managed to get through their scar tissue, but not been able to do a gastric bypass. We probably predicted we weren't going to be able to do that, and we've done a sleeve gastrectomy because we haven't had to deal with the adhesions of the small intestine. So we often, and I suspect many other centres may do the same, is if somebody's desired operation is the bypass involving the small intestine, but there's a good degree of scar tissue inside the tummy, potentially from previous surgery, we often say to a patient, look, we need to think about a plan B now. You don't want us to wake you up, tell you didn't have an operation because we couldn't do it. Do you want us to think about doing a big cut in your tummy, dividing all that scar tissue, and then doing the gastric bypass only, which comes with very, very big complications related to the wound and access, I can tell you? Or do we press on with keyhole surgery, but do the sleeve gastrectomy as that plan B? And we have that conversation pre-operatively. Of course, we have to make that consideration for the reasons as well. Somebody whose weight might be too high for a gastric bypass, we can't get the intestine to reach the pouch, that we want to have had that conversation before. So we try to have a pragmatic discussion about, well, what if? But as surgeons that do weight loss surgery are surgeons that do lots and lots of upper gastrointestinal and emergency general surgery on the guts all the time. So we're well used to coming across internal scar tissue, making things tricky.
Thank you. Just have a look, we've got lots of questions. Just trying to go through them. Questions about after surgery. So do we need to be off work after the operation to recover, and how soon can you go abroad?
It depends what you do really in your job. If you are in a job where you're mainly office based, again, it's an individual type thing. Generally, we say after a couple of weeks, you can go back to work. If you do heavy manual lifting, it may be longer than that, between 4 and 6 weeks. Flying, what do you say? I know we've got it in our booklet. I can't remember what we say about flying. What do you say, Jodie?
Oh, well, this is a tricky one now, isn't it?
Yeah.
Because we have a lot of people flying back after not so many days from abroad after bariatric surgery. And we've always erred more on the side of caution. So depending on what type of flight, if it's a you know, a less than 2 or 3 hour flight, then we would say you need to wear your anti-embolism stockings and ideally be at a stage in your diet where you're feeling quite secure. So 6 weeks plus. I think very often when you're on these long waiting lists and times, people do book holidays, and I think you really need to consider that when you're offered the date. You want to have that holiday, you've been waiting a long time, you're not going to go to the bottom of the queue, so don't be thinking, oh, well, if I go on my holiday and then go maybe risk it you know, 4 weeks after. I think you're probably better just saying, could you give me a date when I get back from my holiday?
Thank you. And I've had a few questions about surgery abroad. So I have put in the link in the chat. I'll put it in again in a bit, with our session from last month, where the surgeon at Salford Royal did cover this topic. So you can catch up on that webinar and the ABL Health YouTube channel. So I'll post that link in